Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hi everyone, it's Susan Kaufman. I'm here for Attitude Magazine and you're listening to Attitude's ADHD Experts podcast. One of the most difficult aspects of attention deficit disorder can be getting the right diagnosis. I mean, so many of the symptoms of ADHD overlap with those of other disorders that making sense of the symptoms can be a challenge. So today, we're very pleased to welcome back Dr. William Dodson, who joins us to discuss one condition, bipolar mood disorder, that is very frequently confused with attention deficit disorder. Some of the topics that Dr. Dodson will address include why mood disorders such as bipolar disorder are the most common misdiagnoses in adults and kids with ADHD, how you can tell the difference between ADHD and bipolar disorder, and how do you treat when both those conditions coexist. Dr. Dodson has been with us before. He's a wonderful explainer of things that are complex. He is a board-certified adult psychiatrist who has specialized in adult ADHD for over 23 years, a life fellow of the American Psychiatric Association. He's the recipient of numerous awards, and his upcoming book is entitled What You Wish Your Doctor Knew About ADHD. For more information, visit his website, dodsonadhdcenter.com, www.dodsonadhdcenter.com. Dr. Dodson, thank you so much for joining us today. We are grateful as always.
Always good to be here. The first question that you have to ask is why at an ADHD website are we even talking about bipolar? The reason for that is that most American clinicians, psychiatrists, etc., are going to see what they've been trained to see, which is mood disorders. Most psychiatrists, most pediatricians receive absolutely no training at all on ADHD. 93% of adult psychiatry training programs don't mention ADHD in 4 years of training. So most psychiatrists are going to be functionally illiterate, and they're going to recognize what they've been trained to recognize, which are mood disorders. And that's what most clinicians are going to see, is the mood changes and not necessarily the ADHD. The other problem is that bipolar and ADHD often occur together. Up to 25% of people with bipolar are also going to have ADHD. So we end up with both of them quite often. The basic statistics about how common these things are out in the real world is that ADHD is somewhere between 5 and 10%. The Centers for Disease Control number, which is the one I use, is 9.9%, about 1 in every 10 people. Bipolar mood disorder is considerably less frequent at about 1% of the population. The new Diagnostic manual has this name bipolar spectrum disorder, which I dislike and find very sloppy, but they estimate it to be about 2.5%. There's also another condition that unfortunately is called bipolar type 2. It actually has no relationship to bipolar type 1. It's poorly understood, poorly researched. We really don't know how common it is, but it's assumed to be somewhere around 2%. So how do you tell the two apart? Well, the first thing is bipolar mood disorder is exactly that. It is a disorder of mood. It's a disorder specifically of the level or intensity of mood. The moods that people have are universal. Sadness, everybody's experienced. Irritability, everybody's experienced. What makes it a disorder are the mood shifts are not triggered by life events. They have a life of their own. They come out of the blue for no apparent reason. The moods change gradually over weeks to months. In fact, a rapid cycling bipolar only needs 4 mood shifts in a 12-month period. So it's not something that happens very quickly. Nothing that the person does makes their mood any better. Nothing's pleasurable, and they try everything they can think of because it's an awful way to feel. Now, the mood has to persist without a break for at least 2 weeks, and that was put in there to help distinguish it from ADHD. The symptoms come and go with periods of relatively normal mood and behavior, usually during the summertime. And so there are times when a person's ill, time when they look absolutely like anybody else. The average age of diagnosis is somewhere in the mid-20s, about 25, 26. Again, very strongly genetic, as just about everything in psychiatry is. You're going to have other members of the family have a diagnosis of bipolar as well, but it's going to be uncommon. There'll be one, maybe two other people. When you look at ADHD, it actually is very different. Again, people with ADHD have very intense emotional lives, but their moods and their mood shifts are very different. They are clearly triggered by what's going on around the person. A person's able to look back and say, yeah, I have mood shifts that are pretty dramatic, but I can see what caused them every time. Consequently, the mood matches the nature of the trigger. If bad things happen, you feel bad. If good things happen, you feel good. The shifts are instantaneous. They happen immediately. And they last until the person gets interested in something else. In other words, in ADHD, the mood shifts are normal moods in every way except their intensity. People with ADHD are very intense, passionate people. Also, with ADHD, by definition, you have to root it in childhood. The impairments must be consistently present all the way back into childhood, the very first memories. ADHD is strongly genetic, but very strongly genetic. Half of the first-degree relatives, brothers, sisters, parents, aunts, uncles, will also have a diagnosis of ADHD. So you can see that they are actually very different conditions, and really they're only joined by the notion of mood shifts. In depression and bipolar mood disorder, the depressive phase is the one that's there by far much more frequently. In fact, to get the diagnosis of bipolar, you only need one manic episode in your entire life. Just about all the others are depressive. And so what you're going to hear are feelings of sadness, hopelessness, apathy. The person doesn't have interest in anything, and especially they can't derive pleasure from anything that used to be pleasurable. They have feelings of guilt and regret. There is a sharp decrease in energy. And in bipolar, it's referred to as leaden paralysis. That means that you're still sharp upstairs. You can still think and remember, but you just have no energy. It's like you're made of lead, and it is everything a person can do to get up and go do anything. The appetite's all over the place. It can be radically increased or gone altogether. As with any depressive mood disorder, there are thoughts of suicide and death. The manic phases are a swing in the other direction. Most people think of mania as being a euphoria, just being on top of the world. But that's only about 30% of manias. 70% are extreme irritability, rugged, raw, explosive irritability. There's grandiosity, they tremendously inflated opinion of their abilities and their importance. Very poor judgment, again, because they feel so good, why could any of this be bad? And so they end up using alcohol and drugs, gambling, promiscuous sex. Again, they just don't see any problems at all. Very rapid speech. And again, this is another thing that gets it confused with ADHD, but usually the speech is going by so fast you can't even follow it. These folks behave very aggressively. They have a decreased need for sleep, a dramatic boost in sexual interest and acting out. And in extreme cases, you can get frank psychosis, delusions, hallucinations, breaking with reality. It becomes really quite severe. So while the depressions are quiet, the manias are very public and very loud. So the look and feel of a bipolar mood disorder, if left untreated, bipolar gets progressively worse. The term is it kindles, or people get sensitized. The episodes get longer. The episodes get more impairing. The time in between when a person has normal moods gets shorter and shorter. And the most common reason for that is that people stop the medications that work so well when the episode is over and they feel better. So it's very important to emphasize that treating this episode of either depression or mania not only treats this one, but it prevents worsening of the condition as time goes on. So even when a person's feeling good, they need to continue taking the medication. So when somebody comes in and they sound depressed, what is it that should make somebody think, I need to check to see whether this is bipolar or not? Again, a history of multiple depressive episodes in which a person is unable to experience any pleasure. Also, constant anxiety. In fact, that's usually one of the major complaints of people with a bipolar type depression, but it's an anxiety that's not relieved by anything. The traditional anxiety medications or alcohol really don't touch that anxiety. Also, they've tried lots of antidepressant medications and really not seen much benefit, or maybe you saw something for a couple of weeks and then it went away. Interspersed in that depression, you can see very short, hours to a day or so, periods of extreme well-being, high energy on top of the world's tremendously productive, and we call these hypomanias. They're not manias that get you into trouble. You just feel great, but only for a couple of hours. There are periods of overspending, increased sexual activity, and risk-taking that you don't see in the traditional major depression. Alcohol and drug abuse is extremely common. About 40% of people with bipolar will attempt to self-medicate themselves with the alcohol and drugs that are available to them in their regular lives. The big problem is most doctors are not going to recognize the possibility that ADHD might even be there. They're only going to see the mood. A study published out of the University of Cleveland was looking at physicians, psychiatrists, seeing people with adult ADHD. Every single time, the study was looking at what was it that made the doctor think of the possibility of ADHD. What happened was that in a year, they never did. Every single time they diagnosed a mood disorder, usually a bipolar variant, and even when 6 patients broke the protocol and said, look, this is a study of ADHD, that's all I've got, all 6 times the psychiatrist told them, no you don't, you've got bipolar. So even when a patient is there telling the doctor the diagnosis, most American psychiatrists are going to refuse to even consider it as a coexisting condition with ADHD. So the place to start with the treatment of mood disorders is with medication. We really have very little to offer people who are in the depressed phase of bipolar disorder. By far the most important thing is to prevent somebody from ever getting into the depressed phase in the first place. We do have a fairly new medication, lorazepam or Latuda, that has revolutionized the treatment of bipolar depression. Other than that, electroshock therapy was about the only thing that could really pull somebody out. There's actually no research evidence that traditional antidepressants have any benefits. And in fact, some evidence, not great, but some, that they actually can make bipolar disorder worse. On the manic phase, The old standby is still lithium. Nobody really knows why lithium works. It was discovered by accident, but it is the mainstay of treatment in bipolar disorder. We also now have what are called atypical neuroleptics. These are much more easily tolerated medications, such as Abilify, Seroquel, Risperidone, and others. They all seem to work equally well. What you choose them on is how little side effects that particular medication will have. Also, over the years, we've recognized that some anti-seizure medications, anti-epilepsy medications, such as Depakote, which is valproic acid, or carbamazepine, also can work almost as well as lithium can. In cases where a person is clearly psychotic, the traditional neuroleptics, such as Haldol, are very commonly used. So the goal of any treatment is to prevent the cycling. We're not real good at raising depressions, and we really don't want to clean up the mess of manias, so we want to prevent episodes of mood changes. And again, the treatment of choice there has always been lithium. There's another medication, one of the anti-epilepsy medications, lamotrigine, that there's a lot of clinical lore that it helped prevent people going into the depressed phase. The problem is that when that's been looked at in research, there's no evidence that it does. Nonetheless, lamotrigine or Lamictal is very commonly used as a preventive medication for cycling. It's very well tolerated, doesn't do any harm, but it's unclear how much benefit it has. So, can bipolar and ADHD be treated at the same time? All of the published research worldwide is on children who have both bipolar and ADHD. Thus far, there's not a single piece of research published on adults who have both conditions. Luckily, what we learn from kids seems to be readily applicable to adults as well. This is something you really ought to go to a specialist for, somebody who has experience in treating both conditions. Of course, finding such a person is extremely difficult. You'll really have to look, again, go to places like CHAD or to the referral page of the Attitude website to look for people who do have previous experience with this. The most important thing is that the mood has to be completely stable for a month or two before stimulant medications for the ADHD can be started. Again, you start low, you go slow. But when you do, what we found is, as with children, adults get more mood stability. In fact, adding stimulants once a person's stable increases the stability, dramatically cuts down on the number of cycles the person has after that. Manic activation is uncommon. That's sort of a general overview of the two disorders separately and together. And at this point, we'll open up and let Susan ask some of the questions that you've asked.
Thank you, Dr. Dodson. So people are intrigued by the idea that children can be diagnosed with bipolar disease. Is that new, or is that been the case for some time? And is the diagnosis of children different than the diagnosis in adults?
Yes, it is. The research started about 1990, so it's been around quite some time. It is still controversial outside of North America. For instance, in the United Kingdom, they do not see any child as ever having bipolar disorder. In this country, especially in the research that's come out of Harvard, where they've been able to follow severely disturbed children for decades now, what they see is the vast majority of these children ultimately become bipolar as adults. They look very different. If a child is diagnosed with depression prior to puberty, 50% of those children will ultimately go on to be diagnosed as bipolar in adulthood. Euphoria is very rare in childhood bipolar. Instead, what you see is extreme irritability and fits of temper that are called affective storms. And this is more than a temper tantrum. This is a destructive rage that goes on 5 or 6 hours. It's not something that's going to be missed or thought of as just being a cranky kid. This is very severe. They tend to be very grandiose. They tend to have almost magical beliefs about what their powers are. And they also tend to be hypersexual. Great sexual preoccupation that in the first years, there was a long period of time when these kids were thought to have been sexually abused. And it only, again, at the 20-year mark, we see that these kids are instead coming out to be bipolar. So while it is extremely rare, maybe 1 in every 5 or 6,000 children, it is a very devastating condition. And ADHD is a marker for this condition. If you see the bipolar emerge before puberty, 95% of the time the person is also going to have ADHD. So it's almost a one-to-one co-presentation.
Wow. There are a couple of people on the webinar. Lindsay is one whose children have been diagnosed or described as having a mood disorder, non-specific, sort of an unwillingness to diagnose them as having bipolar disorder. Is that common also? That it's difficult
Yes,
in children to get a bipolar disorder diagnosis?
Well, it isn't, and fads come and go in psychiatry the way it does every place else. There was a period of time where every kid who had severe temper tantrums got labeled as being bipolar. That tendency is now swung back to where really the bipolar designation is really reserved for these children who have true affective storms. These are memorable. Once you've seen one, you'll never forget it. And again, this is not in the literature, but one of the things that I use clinically is I ask the parents, have you ever been scared of your children? Or have you been afraid to go to sleep with them in the same house? If they have, I wrongly consider the diagnosis of bipolar. A kid who's just ADHD, the parents are going to go, what are you talking about? My child's absolutely delightful most of the time.
Okay.
So again, that's one of the things I use.
Well, it's interesting you say that because one person here on the webinar is saying that they are afraid of their child who has a focus on knives. And so in that case, this is clearly beyond ADHD, I guess is what you're saying, right?
Yes.
Yes. So this is a psychiatry situation. Is there an age at which bipolar tends to manifest itself, both in children or later in adulthood?
Right. When you look retrospectively, the average age at which the moods become unmoored, they become no longer tied to the events of what's going on. But the person still functions okay. The average age is 17.7 years, so late high school.
Wow.
But the diagnosis lags that 9 to 10 years. Again, the disorder gets progressively worse, and the average age of diagnosis in the United States is 26. So again,
10 years too late. I mean, 10 years later than it should be, right?
Right. So it takes a while.
Yeah. I was very interested to hear you say that extreme anxiety was a symptom of bipolar. I wasn't aware of that. And we also have not frequently found anxiety disorders coexisting with ADHD. But is it different? Yes. Is there a difference?
Yes. And right now, worldwide, depression and anxiety are currently kind of thought of as being almost the same thing. The same medications are used to treat them, for instance, the SSRIs. The United States is peculiar in that you have to have one or the other. Either you have to be depressed or you have to be anxious. Everywhere else in the world, you can have what's called mixed anxiety and depression. And that's 85% of the time. That's the diagnosis you're going to get in Canada or Europe or whatever. Again, it's just a peculiarity of how American psychiatrists are trained. So that what you're looking at is in bipolar, people talk about being anxious, but really they're rubbed raw, they're driven inside. When I'm trying to tease it apart, I ask the question, can you tell me more about your baseless, apprehensive fear? Which is the definition of what an anxiety is. A person feels like something awful is just about to happen. People who have bipolar will talk more about it's a relentless drive inside them that they call anxiety, but it doesn't respond to any of the traditional treatments, the benzodiazepines like Valium, that sort of thing, the SSRIs. Those things seem to bounce off. About 30% of people with ADHD will also have an anxiety disorder, but these look like the traditional anxiety disorders. They'll have panic attacks, they'll have OCD, they'll have phobias and that sort of thing, and they respond within a couple of hours sometimes to the standard anti-anxiety medications.
Interesting. So Courtney asks whether she's been diagnosed with, she's had panic attacks and was also diagnosed with bipolar disease, and wonders whether panic attacks are common among those with bipolar disease.
Again, most people with ADHD have won the negative genetic lottery. 70% of the time, a person with ADHD is going to have another major psychiatric diagnosis. 58% of the time, they're going to have two or more. So it's when a doc is doing an evaluation of somebody with ADHD, the question is how many conditions are there, and teasing them apart is where the psychiatrist earns his money. And it's something that takes a lot of time. And again, that's one of the reasons why managed care companies hate the diagnosis of ADHD, is it's very hard to do an initial assessment of an adult in anything under 90 minutes. It's very hard to do an initial assessment of a child in anything under 3 or 4 sessions. Usually because you have to go through and look at everything else as well. So the treating multiple conditions is the rule, not the exception.
Okay. Here's, in terms of the diagnosis issue, here's a person, KB, who says, my ADHD appears to be helped by Lamictal. Does that mean that I'm likely to have a diagnosis of bipolar?
No.
He says that he's been on ADHD meds for 15 years and they lost their efficacy, so his therapist added Lamictal.
The whole idea behind using Lamictal is that it just soothes the nervous system. That's how it was thought of when it was used into the anti-seizure medication, is that a nervous system that's just a little bit raw, it soothes it. And so many people report feeling much better on Lamictal. Is it treating something specific? Nobody knows. But a lot of people say, I just feel better when I take Lamictal.
Interesting. So we don't know that this is necessarily treating bipolar disease at all.
Right.
Right. Okay. Again, in terms of ADHD and diagnosis, Lorraine says her pediatrician once said that ADHD can, quote, turn into bipolar disorder. I mean, what's your point of view on that?
20 years ago, when they were first looking at childhood bipolar, a lot of people who just didn't like the treatment of children with stimulants wanted to blame stimulants as the cause for these children who had, again, a rather dramatic, severe mental disorder. That was researched and found there was absolutely nothing at all to it. The use of stimulant medications does not cause ADHD, it does not does not cause bipolar, doesn't trigger bipolar. In fact, that's been looked at in 3 very large studies where they gave stimulants to kids diagnosed as being childhood bipolar who were not on bipolar medications, and not a single one of these kids over a year's time actually went into an episode. So that has been thoroughly disproven.
Right. Interesting. So ADHD can't turn into bipolar disease.
No.
In the same token, is anxiety in ADHD children an indication of potential bipolar? Not really, based on what you said, right?
Not really.
No. Okay.
One of the things to look for is almost always you're going to have some first-degree relative out there, an aunt, an uncle, somebody like that, who has a diagnosis of bipolar. They're being treated for it. They've been hospitalized for it. That should be a tip-off more than anything else that you need to consider the possibility of bipolar.
Okay.
Doesn't make it a sure thing, but it ought to make the doctor think of that, consider it.
Okay. A strong genetic link.
Yeah.
ODD. I guess, Marjorie, and this has come up before, is it possible that children who are diagnosed with ODD as an extension of ADHD actually have bipolar disorder?
Sure. Again, going back to something I said earlier, where ADHD, if the bipolar manifests itself before puberty, 95% of people have ADHD. Well, 95% also have oppositional defiant disorder.
Oh, wow.
It's a triad. You see those 3 occurring almost always. And again, the earlier the onset of the bipolar disorder, the more likely you are to have both ADHD and oppositional defiant disorder. That's why these kids are so very difficult to treat and manage.
Wow, very difficult. Hannah says her 9-year-old son has meltdowns at school that can last up to an hour and is extremely irritable. Most of the symptoms take place at school. He has an ADHD diagnosis, but his professionals think he has a mood disorder. It sounds like you might concur that evaluation might be in order.
Absolutely.
Yeah. So where you have severe irritability, it sounds like it's worth investigating. Okay. When it turns to bipolar 2, it's quite, the diagnosis du jour. And you're saying it's really nothing to do, what is it then if it's not anything to do with bipolar mood disorder?
Think of the brain as being a thermostat for mood. Some days are better than others for no apparent reason, but it's within a fairly narrow range, just the way a thermostat on the wall would keep the temperature of the room in a fairly narrow range. People who have bipolar type 2, their thermostat is set much lower so that their good days are never as good as other people's bad days. The technical term for it is dysthymia. From 200 years ago when they thought the thymus gland regulated mood. Out of that period of constantly being a bit depressed, there are periods of hypomania that pop out for an afternoon, maybe a whole day, where the person just feels great, on top of the world, and then boom, right back to this low, moderately depressed lifestyle. That's bipolar 2.
Okay.
And again, in this country, we basically say, does the mood just go down? That's unipolar, or can it go up and down? That's bipolar. And so they're identifying 2 different patterns of moods that go up and down. Bipolar 2 is a much more mild, pastel mood disorder as compared to bipolar.
Interesting. And so you think that we will begin to recognize that it's a serious, a recognized disorder? It sounds like it's not yet really.
Oh, it's recognized.
Oh, it is.
It's just unresearched.
Okay, unresearched.
We really don't know how to treat it.
Really interesting.
We use the standard antidepressants and stuff like that because it's what we got. But
do they work for bipolar 2? You said that they didn't really. Standard antidepressants don't really work for classic bipolar disease.
Right, they don't. Sometimes they do work for bipolar type 2. There's some very early articles from back in the 1980s that worried that the traditional antidepressants like the tricyclics could actually kick somebody who was bipolar 2 into a mania. But again, they were open label, they were poorly done, and it's a condition that's just been ignored.
Okay, interesting. Huh. There are a number of people who have questions about reactions to medications. Again, looking for hints in there. So here's a person who was diagnosed as an adult with ADHD, told he did not have bipolar disease, but his stimulant medications lead to extreme sexuality and riskier behavior only when he's medicated, and he's wondering whether this might suggest that bipolar should be considered again.
Go back and consider it again. And again, the doctor's going to need to take a very detailed history, but that's very unusual.
It is
for it to be just that particular symptom and not other things. So I have to say I really don't know. That's a stumper.
Right. Okay. Similarly, another person who says her child on ADHD medication becomes much more angry, on the Lamictal becomes much more angry and irritable. That's probably not a common one either, because it's usually treated for the opposite.
Not.
Yeah,
No.
Interesting.
Lamictal is one of those medications very, very low in side effects. And it's people either just sort of feel, again, it's a vague thing, I feel better when I take it than when I don't. But usually there are no downsides where it makes something worse.
Right. Interesting.
So that's just going to be an idiosyncratic reaction.
Right.
It's a unique to that individual.
And we know that people do have idiosyncratic reactions to medication in general, right? Each person.
Yes.
Yeah. Here's a 13-year-old who's had anxiety for years and irritability and a fondness for pornography. She's been evaluated for ADHD and not diagnosed with it. Her brother and two sisters have ADHD and her mother has bipolar disease. Should she be evaluated for bipolar disorder? It sounds like the answer to that is yes.
Yeah.
Yeah.
Again, the hypersexuality is especially, and you're talking about this patient being a girl.
13-year-old girl. Yeah.
The hypersexuality, that needs evaluation. That should be a tip-off that we need to look into this in depth pretty quickly.
Right. Okay. Just want to come back to one thing you said that I think is really important and extremely interesting, and that's the difference between the way moods change with ADHD and with bipolar. Barbara wants clarification on that. She said you say that bipolar cycles slowly and ADHD mood disorders are triggered by actual events. Can you re-describe that? Because I think it's really pretty critical in terms of differentiating one from the other.
Right. Just because moods change doesn't make them abnormal. In bipolar, what does make it a disorder is not the moods themselves. The moods that people have in bipolar disorder are universal life experiences. We all feel down, we all feel blue, we all feel irritable, we all feel some days we're just revved up. What makes a disorder is that it has no apparent cause. These moods come for no apparent reason. Even when we search for a reason, we really can't find one. And so, the words directly out of the manual are, the moods have taken on a life of their own, separate from the events of the person's life and outside of the person's conscious will and control, and they have been sustained without a break at least 2 weeks.
Okay.
And that's going to be any mood disorder.
Right.
ADHD is always triggered. The type of emotional reaction matches the nature of the trigger. The mood shifts are instantaneous. They happen in the twinkling of an eye. In other words, they're normal moods in every way except they tend to be very intense in people with ADHD. And they then pass, if the person says, I'm going to go get interested and engaged with my video game, all of a sudden the mood is gone again.
So it's the emotional
that's ADHD.
Intensity, the swings, the over-response quickly to things happening around you that distinguishes, that characterizes ADHD. It's really, it's very different from what you described with bipolar, indeed. So interesting. Let's see. There's a lot of questions here about medication. So just to clarify, says Amber, bipolar disorder is mood dictating energy levels and not depending on circumstances. But in ADHD, the mood is circumstantial and energy is not lessened by the mood. Is that correct? She's, I think, restating.
She got it.
Okay, you got it, Amber. That's a great distinction. Yeah. One person here, the son, is considering bipolar because their child's irritability and anger on ADHD meds. He says he feels like the Terminator on his medication and Dr. Jekyll and Mr. Hyde when he's off. Is this normal, or should they be considering bipolar?
The first thing to consider is that the dose of medication is wrong.
Right, too high, yeah.
The rule, capital T, capital R, the rule is that if you have the right molecule at the right dose, you should see no side effects. All you should see are benefits, and the person should feel themselves. They don't feel like their personality is dampened or irritated or whatever. Again, one of the things I really emphasize is right molecule, right dose is a return to normative functioning without side effects. So when somebody's like really irritable, only on their medication, virtually always the problem is either that the dose is way too high or that the person is adding on another stimulant on top of their ADHD medication. High caffeine drinks, Monster, things like that, Red Bull, are very popular among kids, starting at a very early age, added on top of a very finely tuned, fine-tuned ADHD medication is going to make them just rubbed raw irritable, and it's always the ADHD medication that gets blamed, not the caffeine drink.
Interesting. So it could be some over medication and some combination. Right?
That's the way to bet. Okay.
Yeah, here's a person who says her son on Vyvanse and Abilify is always in a bad mood. So, yeah, it's hard to say. As usual, we have some questions about alternatives to medication. I think it's very common for everyone to hope that there's something in food, nutrition, exercise, other areas that can treat bipolar and or ADHD. Do you want to comment on that?
Sure. The one positive one is exercise. Again, virtually nothing in the literature on it, but if you go to a CHAD meeting or a NADDA meeting or something like that, what you're going to find is somewhere around 10 to 20% of people report it's very clear that when they have good aerobic exercise for the next 4 hours, their functioning is as good or better than a first-line stimulant medication. It is a dramatic benefit. It's the slang that you'll hear. It's called the Michael Phelps phenomenon.
Right.
He's very public about the fact that he has ADHD, but he hasn't taken medication for it since he was 8 when he started swimming. And so he's a guy, works out 5 or 6 hours every single day. That's how he treats his ADHD.
Mm-hmm.
I usually get these folks when they break a bone, they get an ACL tear, they can't exercise, and all of a sudden they just really don't function in their lives anymore.
Right.
So, I mean, they're tremendously physically fit until they can't exercise. In terms of food, again, more than 60 very good double-blind control studies, I mean, like gold standard studies, have shown that food has no role in ADHD. What you eat doesn't cause it, doesn't make it better, doesn't make it worse. Food seems to be totally neutral with ADHD.
Interesting.
And there was a recent study, again from the European Union, but it was published in the United States, that reviewed all of those things, all the different non-medication based therapies. This was back in 2013, just a year and a half ago, and basically came up with nothing. They did note 2 open label studies of fish oil that had barely detectable benefits.
So exercise is the name of the game. Yeah, makes sense. Exercise is pretty good for everything, doesn't it? How about the role of hormones? 2 people asking about that. One is concerned about her daughter, who has ADHD and bipolar, some mood disorders. She's wondering about postpartum depression, whether the hormones related to pregnancy can be dangerous for her. And another person who is actually on the webinar is asking about her symptoms, which seem much more onerous, depending on the hormone levels in her body.
The answer is absolutely. Clinically, we see this all the time. There is precious little research on it, though. It's one of these things that the old saying is, if men had to deal with all of these things, we'd have had research 50 years ago.
Definitely.
Yeah. The statistics are this. A woman who has postpartum depression, 50% of the time is going to be diagnosed as bipolar at some point later in her life.
Really?
Yes, very, very high. And if you look at what triggers bipolar episodes, 3 things are notorious for it. One is the change of the seasons as the days get shorter are a trigger for mania. About 80% of manias happen from mid-October to the 1st of December, and in the southern hemisphere it's 6 months out of phase. It's the shortening of the day that causes it. Second most potent trigger is the last month and the natural end of pregnancy, when hormones just go all over the place. That's a trigger for mania. And then sleep deprivation is the third most potent trigger for mania and bipolar mood cycles. If you look at women with ADHD, they're going to have PMS, premenstrual dysphoric disorder is the current term for it. It changes every 3 or 4 years. Are going to have PMS much more frequently, much more severely than the general population. And during that 3 to 5 days, right before the menstrual flow, the ADHD medications really don't work very well at all. And increasing the dose doesn't do a thing. Estrogen, again, it's not everybody. It's about 50-60%. Estrogen just has to be there in order for ADHD medications to work.
Oh, wow.
Same thing goes for menopause. A lot of women report, I've been through menopause and my ADHD medications just don't work at all. And I don't sleep well. I can't do math in my head anymore. I mean, it's a fairly significant impairment. And again, it's one of the indications for hormone replacement therapy. And the nice thing is you'll know very quickly, at 30 days on a Vivel dot or something like that, and just all of a sudden feel much better, sleep much better, the ADHD medications work again. It's not something that you're going to miss. It's a dramatic improvement. Wow.
Okay. Here's a note from someone who's really wondering whether the symptoms of ADHD, which is sleep deprivation, lack of sleep, eating poorly, whether that doesn't indeed lead to symptoms that might look like bipolar, and wouldn't it be, he's wondering, difficult to diagnose bipolar given the behavior of an ADHD person?
Again, bipolar and ADHD share 14 features in common. So there's a lot of overlap. What we really don't care how they are similar. what we care about is how are they different.
Mm-hmm.
That's what helps us separate them. Is it one? Is it the other? Is it both?
Right.
And so those criteria that we've been through twice now, that's how they're different. That's how you figure out which one is which.
Okay.
So a lot of
So
people
it's really not hard to distinguish. I mean, I'm not saying it's easy, but
right.
It is distinguishable.
Yeah, and looking at how they're the same leads nowhere. By the way, in the way we diagnose now, the Diagnostic and Statistical Manual, overlap is built into that particular document. There are 295 named conditions in the DSM-5, but there are only 162 symptoms. So that all of these diagnoses have lots and lots of symptoms in common.
Right.
What we care about is what separates them. What are the things that makes each one a clearly distinctive entity?
Okay.
So that's true in all of psychiatry.
Okay. So in terms of diagnosis, there's a couple of people are asking, what's the best professional? I take it as a psychiatrist for diagnosing ADHD and bipolar, or at least bipolar.
As far as ADHD goes, I have a very dim view of my colleagues. The book that we're trying to get published is entitled "What You Wished Your Doctor Knew About ADHD." It's just not taught in medical schools and specialty training programs. So it's one of those things where you have to go out and find a physician who has been willing to spend 2,000 hours on his or her own to get hot and competent with ADHD, child, adolescent, and adult.
Okay.
How do you find that person? You can go to the Attitude website. You guys have some good referrals there. You can go to the adult ADHD website, nadda.org. Now, the best place to go is go to a CHAD meeting.
Absolutely.
Talk to people. Yeah. They'll tell you who's good in your area, who you can go to and have confidence in, who you need to avoid. They're just a year ahead of you, and they can save you a whole bunch of grief and money by getting you to the right person who's largely going to be self-educated.
Interesting. Yep. Okay. Very disappointing that we don't have better diagnostic, wherewithal here in this country, but we don't, I guess. Yet we're ahead of Europe.
The rest of the world. We're ahead of the rest of the world, but it's still pretty miserable.
Right. So several questions here. I think you might have answered these, but let me try again. Can Adderall or other ADHD medications increase mood disorders or increase anxiety? And I guess I think your answer is if that's the case and the dose is incorrect. Is that right?
Right.
Okay.
ADHD and anxiety in adults, as far as I know, has never been studied. There's not a single research paper out there, but there are 5 in children. And everybody expected the addition of a stimulant to make the anxiety disorder worse, and it just didn't happen.
Doesn't. Okay. All right.
If the medications are fine-tuned.
Right. Okay. All right. How often is ADHD misdiagnosed as bipolar, in your opinion? Probably, yeah. The difference seemed pretty obvious.
The problem is that most mental health professionals, ADHD just never comes on the radar screen. It's not considered at all. And so in that direction, ADHD, diagnosing ADHD rather than bipolar, that rarely occurs. It's almost all in the other direction, where the person has ADHD and all that the clinician sees is the moodiness, the rapid mood shifts. And they'll talk about, at night especially when the person can't sleep, which 90% of people with ADHD spend 2 hours trying to fall asleep, the person will unfortunately tell the doc, my thoughts race and keep me asleep. And on that alone, people end up on lithium. So you really have to distinguish between true racing thoughts of bipolar, where the thoughts are just shooting by so fast you can't pull one out and look at it, versus ADHD, where the thoughts bounce from one concern and worry to another, but with really modest effort, a person can stop, hold on to one of them, think about it, etc. Again, it's use your words carefully. A lot of
That's
words
so interesting.
have loaded meaning to a shrink.
Your description of the racing thoughts bouncing versus jumping from one thing to another it's very clear, the difference between ADHD and bipolar then. Interesting.
Yeah.
Karen says, I've been diagnosed with ADD, OCD, bipolar, and Tourette's, and I have an extremely complex medication regimen. Is it typical to have all these disorders at once? And is it a complex medication regimen normal? Seroquel, Abilify, Lexapro, Nuvigil, Focalin? Sounds like she's got the whole ball of wax.
I really can't comment on her medication regimen, but the answer is yeah, it's very common. In fact, that's what Tourette's is. If you look at the diagnostic criteria for Tourette's, it is just tics. You have to have both movement tics and vocal tics present at least 1 year that you can suppress with effort. That's Tourette's. But clinically what we see is that, again, it's a triad. Almost always the person has the tics, they've got ADHD, and they've got obsessive-compulsive disorder symptoms. And it's the three together. That, in most people's minds, that's Tourette's.
Right. Oh, I see. So, yeah, thinking of a terrific goalie on the U.S. soccer team who's always described as having Tourette's, but then when you read more deeply, he also has ADHD and OCD. Right. Interesting.
Yeah. According to some studies, people with Tourette's are going to have ADHD 80 to 85% of the time.
Mm-hmm. So the answer to her question is yes. It is. It's not uncommon to have this group of diagnoses together.
And each one's a separate condition. One doesn't cause the other, and each one is going to have its own treatment.
Wow. Yeah. That is a lot to deal with. Okay. Well, I think we have so many more questions, but this has been a great overview. I think really helpful, Dr. Dodson, as always. And thank you all for attending, as always. And thank you, Dr. Dodson, especially for all your good, clear overview of this topic. Thanks again, everyone.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.